Good afternoon. We will be continuing for problem-specific part 2 with the elbow and forearm complex, which would be in chapter 18. Please review all the anatomy and function from PTA 150. So referred pain and nerve injury to the elbow region, there's several different nerve disorders that could occur through the elbow, which would be the ulnar, which would be on like your pinky side, the radial nerve, which would be on your thumb side, and median nerve would kind of be right in the middle. There are some common sources of referral pain into the elbow region. If you will please look over those. So for related pathologies in the etiology of symptoms, there are pathologies such as RA, rheumatoid arthritis, or juvenile rheumatoid arthritis, known as JRA, and degenerative joint disease, as well as joint reactions after trauma, or there may be dislocations or fractures that affect the joint complex. Post-immobilization contractures and adhesions can develop in the joint capsule and surround tissue anytime the joint is immobilized in a cast or orthosis. This typically occurs after dislocation or fractures of the humerus, radius, and ulna. So for common impairments in structure and function, there are some different stages that I would like for you to know. So for the acute stage, so when the symptoms are acute, there could be joint effusion, possible muscle guarding or pain that could restrict elbow motion. Usually there is pain at rest. Fractures, dislocations require medical intervention. However, with proper training, obviously not us as a PTA, but if for a PT, if they are trained, they could manipulate or sublux and push or pull the pulled elbow. For the subacute and chronic stages, a capsular pattern usually exists in the subacute and chronic stages of tissue healing. Elbow flexion is more restricted than extension. There is a firm infield and decreased joint play. Usually there's a long-standing arthritis of the elbow. Pronation and supination also become restricted with a firm infield and decreased joint play in the proximal radial ulnar joint. Arthritis of the distal radial ulnar joint results in pain on overpressure. So some common activity limitation and participation restrictions could be possibly having difficulty turning a doorknob or a key in their car into the ignition, or difficulty or pain when pushing and pulling activities such as opening and closing doors. Could have restricted hand-to-mouth activities such as eating or drinking, hand-to-head activities such as personal grooming or using a phone. Pain when pushing up from a chair or inability to carry objects with a straight arm or having an inability to functionally reach certain objects. So for the protection phase, just like a lot of the other pathologies we have spoke about before with the other joints, so you want to educate the patient, you want to inform them on their anticipated length of symptoms. You want to teach them methods to protect their joint and how to modify their daily activities. And you want to instruct them to avoid excessive fatigue by performing exercises frequently during the day, but limiting the number of reps during each bout or set of exercise. You want to reduce the effects of inflammation or synovial infusion and protect the area. So there may be intermittent or limited immobilization in a sling or a static orthosis, which could provide rest for the elbow, but complete immobilization can lead to joint hypomobility, contractures, and limited motion. Therefore, frequent periods of controlled movement with a pain-free range should be performed. So for post-traumatic pain and stiffness are usually common following both operative and non-operative treatment of fractures and dislocations of the elbow. Some soft tissue structures, such as muscles and ligaments, are also subject to damage with certain injuries. To restore function of the elbow, good communication between you as the PTA and the physician are critical for optimal outcomes. It is key to minimize stiffness in early motion. You want to minimize immobilization by using a hinged orthosis, while limiting extension allows for early motion and provides joint protection. You could perform grades 1 and 2 joint distraction and oscillation techniques in the resting position, which could inhibit pain and move synovial fluid for nutrition in the involved joints. You want to maintain soft tissue and joint mobility, such as passive to active assisted range of motion within limits of pain, including flexion extension and forearm pronation and supination. Multiple angle submaximal isometrics for elbow flexors, extensors, pronators, supinators, and wrist flexors and extensors, and pain-free motions or positions is very important. You want to maintain integrity and function of related areas such as the shoulder, wrist, and hand range of motion. Activities should be encouraged within the tolerance of the individual. It would be very easy for them to avoid movement of the wrist and shoulder or their hand due to elbow immobilization or because of pain. So if edema develops in the hand, the arm should be elevated whenever possible. For the controlled motion phase, so for joint hypomobility, if hypomobility exists, range of motion is increased by utilizing joint mobilization techniques, which would be performed by the PT because of its increasing the range of motion. But you as the PTA can perform passive stretching, muscle inhibition techniques, and you could also improve soft tissue and joint mobility by depending on the intensity of stretching and the mobilization techniques, which for you would be grade 1s and 2s for pain, will be dictated by the healing tissues and the specific pathology and surgical technique, the amount of pain, motion, and infill. Vigorous stretching should not be undertaken until later stages of healing. So as noted in box 18.1, high-intensity stretching of the elbow flexors is contraindicated following trauma because of the potential for development of heterotrophic bone formation. Passive joint mobilization techniques are involved in early motion of the elbow. It is important to identify which of the articulation has reduced joint play. Manual stretching and self-stretching. Using manual stretching and inhibition techniques to increase the flexibility of any periarticular tissues that are restricting mobility. Use of a light cuff weight placed around the distal forearm, but the patient carefully positioned for an effective stretch provides a low-intensity, long-duration stretch and is an alternative to manual passive stretching. If elbow range of motion does not steadily improve after acute symptoms have subsided, the patient may need to begin wearing a static progressive orthosis that applies a low-load, prolonged stretch force over an extended period of time. For the return to function phase, you want to improve muscle performance, so by progressing strengthening exercises as the joint tissue tolerates. You want to teach the patient safe progressions and exercise strategies to promote return to function, and you want to prepare the joints and muscles for specific tasks. You want to use exercise that replicate the repetitions and demands of daily activities such as pushing, pulling, lifting, carrying, and gripping. You want to restore functional mobility of joints and soft tissues. If restrictions remain, use more vigorous manual or mechanical stretching and joint mobilization techniques. Again, joint mobilization techniques would be performed by the PT to improve mobility. Promote joint protection. So chronic arthritic conditions may require modification of high-load activities to minimize deforming stresses on the involved joints. For joint surgery and postoperative management, there could a patient could have a radial head excision or arthroplasty. If you look at box 18.2, it'll contain surgical options for displaced fractures of the radial head. This is just for knowledge. I don't expect you to know it to full extent. Table 18.1 shows severity of elbow joint disease and selection of surgical procedures. Again, you do not have to know this in great detail, but you can look over this information. So a total elbow arthroplasty, known as a TEA. If you want to look over the contraindications to total elbow arthroplasty, that would probably be the main significance that I would love for you to look over. So for the post-operative management, if you look at table 18.2, it'll outline factors that influence the progression of exercise after a total elbow arthroplasty. And also there are specific precautions listed in 18.5. I'm going to talk more about the myositis ossificans, which is formation of bone in an atypical location in the body. Same thing is synonymous with heterotrophic or ectopic bone formation. So the term is often used interchangeably to describe the formation of bone in an atypical location of the body. Some resources use the term myositis ossificans to denote only ossification of muscle. So more often the term is used generally to characterize heterotrophic ossification, or bone formation in the muscle tendon unit, capsule, or ligamentous structures. So the etiology of HO following elbow fracture has been reported to be as high as 40% and is most commonly located at the posterior medial aspect of the elbow. HO may develop after a comminuted fracture of the radial head, a fracture dislocation of the elbow, or a tear of the brachialis tendon. Patients with concurrent traumatic brain injury or spinal cord injury, or patients with burns to the extremities have much higher risk in developing this complication. Additional risk factors for developing HO include delayed internal fixation and use of bone graft and/or bone graft substitute. More severe HO is associated with concomitant distal humeral fracture, triad fracture, and elbow fracture dislocation. Delay in intervention can increase the risk of HO, while some believe that too much motion or aggressive stretching following an injury can also exacerbate HO. Others believe that HO occurs due to lack of motion. There is no evidence or consensus to indicate that overstretching or participation in physical therapy contributes to HO. So clinical presentation of HO involves a restriction of joint motion after trauma. So palpation of a locking sensation at the terminal extension or flexion is also an indication of HO rather than of joint contracture. HO begins approximately 2 weeks after the injury, and the patient often presents with swelling, warmth, and pain. As the process continues, the warmth, arrhythmia, and swelling will gradually resolve, which may be accompanied by a gradual loss of elbow motion. Palpation of the distal brachialis muscle is tender. After the acute inflammatory period, the heterotrophic bone formation is laid down in muscle between, but not within, individual muscle fibers or around the joint capsule within a 2 to 4 week period. This makes the muscle extremely firm to touch. Although the condition can permanently restrict elbow motion, in most cases, the heterotopic bone is largely reabsorbed over several months, and motion usually returns to near normal. Some other common related pathologies would be lateral elbow tendinopathy, as known as tennis elbow. So tennis elbow is commonly referred to as lateral epicondylitis. It could also be referred to as lateral epicondylalgia, epicondyliosis, which would be more chronic condition, or lateral elbow tendinopathy. Symptoms include pain over the lateral epicondyle of the humerus, primarily with gripping activities requiring firm wrist stability, such as the backhand stroke in tennis, or repetitive work tasks that require repeated wrist extension, such as computer work or pulling weeds in a garden, can stress the musculotendinous unit and cause symptoms. The primary structure involved is the origin of the extensor carpi radialis brevis muscle, although the extensor dorsatorium is also involved in approximately 50% of patients. A positive test includes palpation tenderness on or near the lateral epicondyle, pain with resisted wrist extension, performed with the elbow extended, pain with resisted middle finger extension, and pain with passive wrist flexion with the elbow extended and forearm pronated. So it's important to keep note too that a pulled elbow, pushed elbow, radial head arthritis, radial head fracture, pinched synovial fringe, radial tunnel syndrome, cervical root compression, and periosteal bruise are also possible associated sources of lateral elbow pain and are sometimes inaccurately diagnosed as tennis elbow. For medial elbow tendinopathy, which is known as golfer's elbow, occurs is also known as medial epicondylitis, associated with, it is near the junction of the medial epicondyle and is associated with repetitive movements into wrist flexion, such as swinging a golf club, pitching a ball, or work-related grasping and lifting heavy objects. Ulnar neuropathy may be associated with these findings. So a positive test is also including palpation tenderness near the medial epicondyle. If pain is with resistive wrist flexion, performed with elbow extended, and pain with passive wrist extension performed with the elbow extended. The most common cause of medial and lateral epicondylalgia is excessive repetitive use or eccentric strain of the wrist and forearm muscles. Excuse me. The result is micro damage and partial tears, usually near the musculotendinous junction, when the strain exceeds the strength of the tissues and when the demand exceeds the repair process. So with the repetitive trauma, fibroblastic activity and collagen weakening occur. So recurrent problems are seen because the resulting immobile or immature scar is redamaged when returning to activities before there is sufficient healing or mobility in the surrounding tissue. Mechanical nerve pain, hypersensitivity over the radial and ulnar nerves, and their nerve trunks have been reported in patients with medial and lateral epicondylalgia. These findings suggest the presence of central and peripheral sensitization mechanisms in the patient population. So some common impairments of structure and function. So gradually increasing pain in the elbow region after excessive activity of the wrist and hand. Pain when the involved muscle is stretched or when it contracts against resistance. Decreased muscle strength and endurance. Decreased grip strength, limited by pain. Proximal weakness of shoulder and scapular musculature. Decreased mobility of the lower cervical and upper thoracic spine. Tenderness with palpation over the lateral and medial epicondyle or tendon origin. Some common activity limitations and participation restrictions could include participation in activities such as racket sports, throwing, or golf, difficulty with repetitive forearm wrist tasks such as sorting or assembling small parts, typing on a keyboard, using a computer mouse, gripping activities such as using a hammer, turning a screwdriver, shuffling papers, or playing a percussion instrument. So during the protection phase for overuse syndromes due to repetitive trauma, you want to decrease the pain, you want to improve joint mobility, soft tissue mobility, and maintain upper extremity function. For the controlled motion and return to function phase, you want to progress them as they can tolerate without increasing their pain You want to increase muscle flexibility, restore the joint tracking of the radial ulnar joint. You want to improve muscle performance and function. And again, a lot of patient education, especially identifying how long the time frame will be for the healing process and when they're able to return to functional activities. Here are some case studies I would love for you to look at. For the elbow and forearm bicipital tendonitis, there is a case study in the score builders, lateral epicondylitis, score builders in Physio U, myositis ossificans would be in score builders. Moving on to the wrist and hand, please review anatomy and function from PTA 150 for the wrist and hand. So there are major nerves subject to pressure and trauma at the wrist and hand, including the median and ulnar nerve. There's referral pain and sensory patterns from the nerve roots of C6, C7, C8, and T1. There's some common joint pathologies and associated impairments. A lot of times might be due to rheumatoid arthritis, depending how debilitating the disease, how and what kind of, if it's mild or moderate or severe. Degenerative joint disease, there's osteoarthritis, post-traumatic arthrosis, post-immobilization hypomobility. So some common activity limitations of participation restrictions could be anything from daily activities of holding a brush, holding a toothbrush, being able to feed themselves, or even dressing themselves. They might have a lot of increased pain and not able to perform their tasks that they usually enjoy performing. So for the management phase, for the protection phase, you want to control the pain and you want to protect the joints. You want to maintain the joint and tendon mobility and muscle integrity. I feel a lot of times this could be pretty challenging, especially if they have, let's say, RA on both hands. It's going to be really hard for them to be fully functioning with limiting pain and being able to perform activities. You want to, during the control motion and return to function phase, increase joint play and accessory motions, perform pain-free motions, and progress them from mobility to strengthening and to return to function. With arthroplasty, a lot of times might be due to trauma and they have to have a wrist arthroplasty. For the postoperative management, there's a time frame of immobilization and a certain progression. So here continued. For outcomes, you want to have pain relief, improve range of motion for the wrist and forearm, progress towards strengthening, and progress them with function. So again, I'm not going in great detail with a lot of these pathologies, as I don't expect you to know them by heart, but just as an overview, so please make for sure that you look over these in your textbooks as well. Metacarpophalangeal implant arthroplasty, there's a procedure that's very similar of how you would do the protection phase to controlled management phase. Same thing with PIP implant arthroplasty. They could also have a CNC arthroplasty of the thumb. So if they have a tendon rupture associated with RA, then they might have to have a tendon transfer or graft reconstruction. Tendinopathy, this might be a little bit more, well, tendinopathy, and a lot of times I think of the shoulder, a lot of times there might be a tendinopathy, but of course throughout their body there also can be, most likely due to overuse, or common activities might be a lot of repetitive trauma syndromes to where they're repeating the same movements over and over again. So if they have a laceration to the flexor tendons of the hand, so obviously they would be a candidate for surgery. They might have been performing either construction work or any kind of work activity that's to where this occurred, and they might have a tendon graft. So usually the flexor or the lacerated flexor tendons of the hand are immediately repaired within 24 hours. And here's the different time frames for if they need a primary repair or secondary repair. So usually they try to get to them pretty quickly. So we're not really going to go over the operative overview, but you can definitely look over those. So for lacerated extensor tendon, a lot of times you want to go through the same phases, especially if they are in immobilization and you want to protect the actual hand in the wound, and then you want to progress them as the healing phases continues and the pain decreases. So the same would occur for that until you could get to the management phase, into the controlled phase, into function phase. I know that was pretty short and sweet and to the point. I didn't really want to go in a whole lot of detail for the wrist and hand. Probably the main things for the wrist and hand is the first pathologies that I mentioned, such as rheumatoid arthritis or osteoarthritis, and how those can limit function. If you please, if you want to look at the Colles fracture or de Quervain's, that's probably pretty common. Having a patient with de Quervain's, there is a case study and more information in your score builders and Physio U. And this was a pretty short lecture covering the elbow and the wrist, but is not as much information compared to the shoulder. Thank you. Have a great day.